Good evening, everyone, and we are welcoming you to our webinar. This is SAP KSA, and I will be the moderator today. This is Mohammed Karar. Today, we have a special speaker, Dr. Selma Abdullah Ali. Dr. Selma is a pediatric intensivist. She is a consultant pediatric intensivist specialized in managing critically ill children. She is also a pediatric advanced life support instructor, and she is working in King Saud University. Dr. Salma also, she did her specialization and fellowship for PICU in Malaysia, and she is MD Sudan, University of Khartoum, pediatrician certified or board certified. Without any delay, Dr. Selma, we are welcoming you to the webinar, and I hope everyone, you have any question. If you have any question, just please write your questions in the question and answer section, better than the chat. Thank you very much for joining us, and let's start the webinar. Dr. Selma, we will hand the mic for you.
Okay, thank you, Dr. Mohammed, for this nice introduction. And today we choose this topic, the PALS overview and updates, latest update, 2025 updates, because this is very crucial for every pediatrician to know how to save critically ill patients. So the pediatric advanced life support is mandatory. And yes, I want to highlight that this review will refresh you, but it is not a substitute for the course, but because taking the course is still mandatory. We'll go through the course agenda. Our agenda, first we will go and touch the PAT, the pediatric assessment triangle, and then we will go through the systematic approach, type of shock, and how to manage each type of shock, and respiratory diseases, the arrhythmia, post return of spontaneous circulation care, and the latest significant updates in the PALS 2025 guidelines. So we start with the PAT. When you are assessing any child in any circumstances, to have a look whether this child is really sick, very sick, or he is a stable patient, or he need resuscitation. So you have to start with this simple audio-visual triangle. The pediatric assessment triangle is a triangle which will allow you to assess your patient from the first look without touching the patient. So first you look at the appearance of the patient. What do we mean by the appearance of the patient? Whether the patient is fully awake, sleepy, lethargic, or he's unresponsive to the surroundings. So mainly we are looking at the level of consciousness of the patient. And then you look at the work of breathing. Because respiratory diseases are the predominant in the pediatric population, most of their illness related to respiratory problems. So you look at the work of breathing, whether the patient is using accessory muscle, whether he is tachypneic or he is comfortable. And then the last part is the circulation. How we can assess the circulation by just visualizing our patient, looking at the color of the patient, whether the patient looks pink, pale, cyanosed, or he is already mottled. So this is a simple way of assessing any patient. So you look at the appearance, as we mentioned, the work of breathing, and then the circulation. Then, because in the past, what I like about it, that you go through a systematic approach. Once you are going systematic, you tend to cover every aspect of your patient, so you will not forget minor issues. So you start your primary assessment with the ABCDE. So A, you look at the airways of your patient, whether the airways is open, patent, maintained or not. And then you look at the breathing of the patient. You look if your patient is having a noisy breathing or no, he's comfortable, and whether your patient is sitting well, working hard, as we mentioned, using accessory muscles. And then after that, you look at the circulation. Circulation had multiple components. You assess your patient, look at the pulse, quality of the pulse, the capillary fill time, central peripheral pulses, look at the color of the skin, whether it is mottled or the patient is pale or cyanose or pink. And then after that, you go for the disability. The disability, what we mean by it, we are assessing the level of consciousness of our patient. And then after that, we look if it is available for us, what is the level of the blood glucose, because pediatric populations, they are sensitive. Once they are hypoglycemic, they can manifest more complications. And then the exposure, the temperature of the patient, and whether the patient is having any apparent traumas, rashes. So this is how you scan your patient by the ABCDE mnemonic. Then after that, you go for your secondary assessment. Secondary assessment, you take a focus history from your patient. So you look at the signs and symptoms, what the patient started to have, what symptoms the patient is having, and when they started, and how severe are the symptoms. And then after that, you look for the allergies and the medication, whether your patient was on medication or not, and the past medical history, and the last meal, and the event which led to the presentation. So if you look at this history, it is a focus history. Because later you can gather more information, but because our aim to save the lives, so we take a focus history, which we can follow the mnemonic sample. Signs and symptoms, allergies, medication, past medical history, last meal, and the event which led to the presentation. After finishing the focal history, then you go for the physical examination. Then when you are starting your physical examination, you start to scan your patient from the head to toe. You don't ignore any part of the examination, because it is very crucial to know what's going on with your patient. So you start from the head. You look for your patient in the usual way that every pediatrician will be examining his patient. So from the head to toe, and don't forget to examine the back and look for any signs of trauma, any rashes, anything. Okay, so now we will focus into the types of shock, because shock one of the serious presentation that pediatric population they will present with, and we have to differentiate between the different types of shock. So I think all of you know that we have four main types of shock. Either the shock is hypovolemic, distributive, cardiogenic, or obstructive shock. So the hypovolemic shock, of course, from the history, you will know that maybe your patient is having a hypovolemic shock. So if the patient was not taken well for many days, if the patient was having vomiting, diarrhea, or the patient had major trauma that led to bleeding, all this can lead to hypovolemic shock. And then once you are going through the examination of your patient, then you will tend to know whether your patient is having compensated shock or decompensated shock. How I will know that? By assessing the different elements that assess the hemodynamics of any patient. So you check the pulse, as we mentioned, and the heart rate, the blood pressure, peripheral and central pulses, the capillary fill, and the urine output. And of course, if the shock is severe enough, it will lead to loss of consciousness. And typical of hypovolemic shock, that the patient will have a decreased preload. But the contractility of the heart will be normal, and the afterload will be increased, because the systemic vascular resistance will, as a compensation mechanism from the body, will increase. And then the patient will start to have increased respiratory rate and effort, because the patient will try to match the demand of the body. That's why he will start to increase his respiratory rate and effort. Although he doesn't have any respiratory problem, it is a hypovolemic shock, but because he wants to deliver the oxygen to the body, he wants to compensate for the gaps. That's why he is having increased rate and effort. And the systolic blood pressure will be maintained as long as the patient is compensated. Once the shock will go to the state that the patient will be decompensated, then you will have hypotension. And of course, they will have a neuropulse pressure and tachycardia. As we mentioned, it is the most sensitive sign of shock. It is the early signs of shock. And the pulses, if it is severe enough, will be weak, and the capillary fill time will be delayed. the usual capillary fill time will be 2 to 3 seconds. Once you reach 4 seconds or more, then it means that your patient is having signs of shock. And the urine output in hypovolemic shock will be reduced. And then if we did not start to manage our patient, then he will progress more, and then he might lose his consciousness. Then we come to the other type of shock, is distributive shock. Distributive shock, typically we see it when the patient is having sepsis or spinal injury or anaphylaxis. Here, the patient does not have losses, but the distribution of the blood went to the peripheries while the vital organs are jeopardized. Then again, the preload might be reduced or it could be normal also. The contractility of heart will be normal, but if it is severe enough, especially in septic shock, and the toxin already affected the myocardium, then the contractility will be reduced. And as we mentioned earlier in the hypovolemic, once the patient start to compensate, then maybe the systemic vascular resistance will be high, and then again they are trying to compensate for the oxygen demands, then they will increase their respiratory rate and effort, and then the pulse pressure might not be narrow as in the hypovolemic. It will vary, and still they will be tachycardic. And the peripheral pulses, typically in distributive shock, when their peripheries are having vasodilation, you will have a bound in pulses. But distributive shock, initially the patient will be warm, but if it worsens further, then they might turn to cold, and then the capillary fill time could be brisk. We come to the cardiogenic shock. This is one of the types of shock that we have to be very cautious, especially if we start to manage the patient with the fluid. You have to make sure that you don't overload the patient, because once he's having a weak myocardium and then you give large amount of fluid, then the heart will worsen further and then the body will decompensate. So if you are seeing any patient, once you are giving fluid boluses, they are starting to deteriorate further, uh, try to make sure whether they are having a congenital heart disease, you are worsening them with the fluids or not. And not all the patients that present with congenital heart disease, we know about them, because maybe you are the first one to discover the congenital heart disease. And sometimes the patient does not have any past history of heart problem, but they are having simple viral infections. And this simple viral infection can lead to myocarditis, and myocarditis can compromise the heart significantly. And then the contractility will be compromised, and then their afterload, when they are in the stage of compensation, will be increased. And again, also they have increased respiratory rate and effort, and their systolic blood pressure while they are on compensation will be normal, and once they decompensate, it will be lowish blood pressure, and they will be tachycardic. Of course, all types of shock, the patient will be tachycardic. And the peripheral pulses in the cardiogenic shock might be weak or absent. And if they are sick enough, also they might lose their consciousness, and also their capillary fill time will be delayed. Then we have the obstructive shock. The types of obstructive shock that we are commonly seeing in the pediatric population is the cardiac tamponade, especially if they are having post-cardiac surgery. They might bleed in the pericardium, and then they will have a tamponade. So you have to be very quick, because this type of shock is lethal also. And if they are having pericardial effusion, also you have to pick that one with the ultrasound or the echo at the bedside, and then try to tackle it very fast. And then tension pneumothorax also is a common presentation, especially during this winter. Those who are ventilated, those who are having ARDS or having severe pneumonia, pneumonitis, or those who are having asthma, they might blow pneumothorax. Secondary to the spontaneous pneumothorax can happen with the asthmatics. And those who are in ventilated patient, you have to, once they start to desat, you have to suspect tension pneumothorax, because it is one of the things that can lead to obstructive shock. And once the patient is having obstructive shock, he will have a variable preload. It might be compromised, might not be compromised. The heart contractility will be normal, but the afterload will be high. And trying to compensate, they will have increased respiratory rate and effort. And their pulse pressure will be narrow. And once they are having pericardial, significant pericardial effusion to cause a tamponade, their heart sounds will be distant, and the peripheral pulses are going to be weak, and the capillary will be delayed. And the danger of this obstructive shock, unless you relieve the tension pneumothorax or you relieve the tamponade, the patient will continue to deteriorate very fast till they will arrest. That's why you have to tackle them very fast. So these are the four major types of shock. And as we mentioned, the key that from the scenario that the patient will present with, you will suspect which could be the possibility, which type of shock. If he is having losses, maybe hypovolemic. If he is having history of fever and he is having cooking infection, so sepsis is there. Or if he had anaphylaxis, then the allergen that caused the anaphylactic shock, you had a history, clear history about it, then you have to manage them because they, as we mentioned, the blood will go to the peripheries and then the vital organs are compromised. Cardiogenic shock, you have to have high index of suspicion, and obstructive, as we mentioned, could be tamponading or could be tension pneumothorax or could be embolism, but embolism is more common in the adult, but still it can happen in the pediatric population. So what is our goals of management of shock? So as we mentioned that we have to improve the oxygenation and we have to ease oxygen demand or reduce the demands for oxygen, and we have to improve the volume and fluid distribution, and we have to normalize the electrolytes and metabolic disturbance. So how can we reach these goals? We can improve the oxygenation by supplementing simply the patient with oxygen via simple face mask or non-rebreather. If the patient is sick, so much sick, then you can go with the mechanical ventilation and relax your patient with the sedatives. This will reduce the oxygen consumption and improve the oxygenation. And if the patient is having low hemoglobin, you have to top up the hemoglobin because we know that having an appropriate hemoglobin level will improve the oxygen carrying capacities. And we have to reduce also the oxygen demand. How do we do that? We have to treat fever because it increases the metabolic rate and then the oxygen demand will increase. Also pain and anxiety, also they can increase the oxygen demand. So you have to make pain and anxiety. And in electrolyte disturbance can add to the complication that the patient already having. So you have to treat the electrolyte disturbances, and then you have to manage the acidosis because acidosis, as we know, it can compromise also the cardiac function, and the patient will worsen his heart failure with the severe acidosis. And if the patient is having hypoglycemia, you have also to treat the hypoglycemia. And how we are improving the volume and fluid distribution, and this depends on the type of shock. So for the hypovolemic shock, it is very clear that we have to replace the volume loss. If the patient is losing fluids, then you have to replace with the fluid. If the patient is losing blood, then you have to give packed RBCs. But if packed RBCs are not there ready, you can start with the normal saline or any isotonic solution that you are having at hand. Don't delay the management of the patient. Start with your fluid boluses and continue to reassess your patient. And if the patient is having a septic shock, then you have to go through the septic shock algorithm. You will give the patient the first bolus, second bolus, third bolus. With the third bolus, then you will have to start your inotropic support for your patient. And if the patient is having anaphylaxis, of course, you have to give epinephrine, IM, and then start the fluid resuscitation. Neurogenic shock, also, you have to resuscitate with fluid and start your inotropes to maintain the vital organs. And if the patient is having cardiogenic shock, you have to tailor your management according to the type of heart disease the patient is having. Because cardiogenic shock can happen second to bradyarrhythmias, tachyarrhythmias, or congenital heart diseases. And if the patient is having a duct-dependent lesion, especially if you are dealing with neonates, then you have to consider prostaglandin, but you have to consult the expert, you have to do the echo at the bedside, diagnose whether your patient is having, for example, coarctation of the aorta, or he's having severe aortic stenosis or whatever that need a duct, then you have to maintain this duct open by administering prostaglandin, paying attention to the possible complications of the prostaglandin, mainly apneas. And if the patient is having tension pneumothorax, he start to, for example, desaturate suddenly. What you are going to do at the bedside, you have to, the area where you are suspecting that there is a pneumothorax, you go for needle in decompression, and then after that you have to insert a chest tube to decompress, because this will cause obstructive shock and the patient might go to arrest if we did not diagnose appropriately and treat appropriately. And as we mentioned earlier, tamponade, you have to go for pericardiocentesis. Of course, for these procedures, the tension pneumothorax, for needling, any pediatrician can do. The chest tube insertion can be done by intensivist, by IR, intervention radiologist, or by critical care ER physician, or by pediatric surgeon. But for a tamponade, if you have a pericardial effusion or tamponading, then the pericardiocentesis is done by the expert cardiologist or interventional radiologist. And the pulmonary embolism, you have to fluid resuscitate your patient, and then you have to consider that you give a thrombolytic agent to dissolve the thrombus. So this is how you manage the different type of shock. And it is very important that once you are managing any type of shock, you continue to reassess your patient. The systematic approach that we mentioned, the elements of the ABCDE and the vital signs and the head-to-toe examination, and focusing on the hemodynamics, you have to keep monitoring your patient. And any patient who is at shock, he deserves that he will be monitored continuously. And this is about the fluid, how you resuscitate the fluid. If the patient is having hypovolemic shock, whatever the cause, bleeding or not bleeding, then you have to give a bolus. Then this bolus is 20 ml per kg, and then you repeat and reevaluate your patient. Those who are having diabetic ketoacidosis, of course, you don't give those who are having mild DKA any boluses, but those who are having severe or moderate, 10 to 20 ml per kg, and then you can repeat it as needed. Then, because with the diabetic, we don't want to go with the rapid volume overload for them, because the cerebral edema is a great risk. So you give them the bolus over longer duration, not like the other type of shock. And the distributive, the septic shock, anaphylactic, the neurogenic, you can give them again 20. You be very careful with the fluid resuscitation. In cardiogenic shock, you can give them 5 to 10 ml per kg. It is not a contraindication that those who are having cardiogenic shock to give them fluid, because sometimes they are on heart failure but they are dry. Still, they need some fluid plus inotropic support. And the obstructive also, they will need fluid resuscitation before you will handle the major problems. Okay. We covered the shock. Initially, I wanted to focus on the shock. That's why I give it more time. But of course, we know that the leading problem in the pediatric is the respiratory rather than the hemodynamic issues. So we will just talk about the main causes of respiratory distress in pediatric population. So as we know that in the past, they have a very nice classification of respiratory problems. They just make it upper airway obstruction, lower airway obstruction, and lung tissue disease, and then disorder control of breathing. This is how they classify. And I like this classification because it does not, although it does not cover all the respiratory problems that we are seeing in the pediatric, but this is the most common causes of respiratory distress. And you have to make sure when you are examining any patient who is having respiratory distress, if this patient is in danger, he need advanced airway or not. Because once the pediatric population, they start to have hypoxia, they desaturate, they cannot tolerate the hypoxia for a long time. Then after that, they might go into cardiac arrest because of the respiratory problem. So upper airway obstruction could be secondary to anaphylactic shock, could be secondary to croup or foreign body aspiration. And the hallmark of this upper airway obstruction will be the stridor. Once you hear the stridor, then from taking the history, you will be able to know which is which. Is it a viral infection causing croup, or it is anaphylactic shock, or the patient is having a choking, then he had these symptoms, then you can suspect the foreign body. Last, and then for the anaphylaxis, as we mentioned, then you have to start with the epinephrine and then support your patient ABC. And then for the croup, then you give the modified oxygen, and then you give IM dexamethasone, and then inhaled racemic epinephrine, and repeat as needed. And if the croup is severe enough, they might need to go into the intensive care unit for frequent monitoring and management, because they might need advanced airway, namely intubation. For the foreign body, it is very dangerous to perform a blind finger sweeping for any foreign body, because you can push it further and then the patient will worsen. And if we are suspecting foreign body aspiration, so as per the PALS guidelines, you do back slaps and chest thrust. And if you are sure that there is a foreign body aspiration, then you have to refer the patient for the expert who can remove this foreign body. And then the lower airway obstruction, either bronchiolitis or asthma with the narrowing of the bronchioles, you will hear the wheezes, and then you have to give them the bronchodilators as needed and continue to manage them. And if you are thinking that there is super added infections, then you have to treat the infections. And don't forget for the asthma that it is one of the things that you have to make sure that the patient is having adequate hydration, because sometimes many days they are not taken very well. And don't forget the steroids as well. And the systemic bronchodilators such as the magnesium sulfates. For the bronchiolitis, you have to keep them well hydrated, and then you have to give them bronchodilators, and then if they are having secretions, you have to take care of the secretions as needed. For those who are having lung tissue disease, namely pneumonias or pulmonary edema, their presentation will be that they will have increased work of breathing, they will have crackles, crepitation, there will be X-ray findings. So you start manage them. You have to supplement them with oxygen, and you have to tailor your management according to their needs. Some of the patient with even the asthma, the bronchiolitis, the pneumonia, the oxygenation will be compromised. So giving oxygen alone might not be enough. You might consider giving them CPAP, high flow nasal cannula, or if needed, the advanced airway, which is the intubation. And those who are having pulmonary edema, they will benefit if you give them the CPAP, because this will help them with the oxygenation. And then you can add diuretics to reduce the volume overload. And those are having this disorder control of breathing, whether they are having a neuromuscular disease or you are suspecting poisoning, which led to the reduced effort of breathing, or those who are having high ICP, which lead to depressed respiration. So you have to support their breathing. And once the patient is not breathing adequately, you can support them initially with bag mask ventilation. Make sure that the chest rise is good, the oxygenation is improving, and if the patient level of consciousness does not improve, those who are having, you are suspecting toxic poisoning, their level of consciousness did not improve, although you have given them the antidote for the poison, and still they are not breathing enough, then you have to consider an advanced airway. And those who are having neuromuscular diseases like SMA or myopathies, they might benefit from CPAP, or they might need to go for intubation. Okay, and those who are having ICP, high ICP, because you want to protect them from the complication of further worsening high ICP, you better go for the brain protective measurement, and then you secure the airways, the earlier the better, and then you can consider mannitol, which will cause osmotic diuresis and then help with the reduction of the high ICP. Okay, so we are finished with the respiratory. We went fast because you know the topic of the pulse is very wide, but we focus into multiple areas so that the people will have a comprehensive idea about the pulse. So now we talk about the tachyarrhythmias. The commonest that the patient will have sinus tachycardia. In the pediatric population, they can have sinus tachycardia secondary to multiple causes, but the hallmark that you will have the sinus rhythm with the P wave, which is normal, and the PR interval is constant, and the QRS complexes are narrow, and the RR interval may be variable, as we know all that with breathing, the RR interval can vary, and this we call it sinus arrhythmia. And the supraventricular tachycardia is one of the commonest tachyarrhythmia that we see in the pediatric population. And we follow the PALS guidelines algorithm for the management of the supraventricular tachycardia. And the hallmark is that you will have narrow QRS complexes unless you are having a reentrant tachycardia, and the P wave will be absent or abnormal, and the RR interval will be still regular. For the ventricular tachycardia, the hallmark of it is that you will have a wide QRS complexes, and the P wave usually we don't see it. And then if sometimes if it is a monomorphic ventricular tachycardia, the shape of the QR complexes will be the same. But if it is a polymorphic from multiple foci, then maybe the shape will be variable. So this is just a rhythm strip. The first one, the rhythm strip in A. This is, as we can see, there is a P wave, a narrow QRS, and the RR interval is regular, so this is a normal sinus rhythm. Here in the rhythm strip B, we are seeing sinus tachycardia. Still, the QRS complexes are narrow, and there is a P waves, and the P waves are normal. And the last one, rhythm strip C, we can see a P wave which is present before each QRS complexes, and the RR intervals here are variable. This is the sinus arrhythmia, and this is normal variation of the RR interval, which happen because of the variability during breathing. So this is still normal. So here we can see what in rhythm strip D, we have seen a narrow QRS complexes. We cannot see any P wave, and the heart rate is very fast. Of course, this is a supraventricular tachycardia, and usually the rate will be above 220 in infants, and in bigger children, more than 180. Okay, so supraventricular tachycardia, if you are managing a patient with supraventricular tachycardia, the most important that you will assess the hemodynamics of your patient. If he is having good perfusion, no signs of hemodynamic compromise, then you go with the vagal maneuvers for the management for the supraventricular tachycardia. And if the patient does not respond, you do 12-lead ECG, consult the expert, and then you might consider giving the adenosine for them. And if the patient supraventricular tachycardia but with signs of poor perfusion, then you go for synchronized cardioversion. Okay, so here in this strip, this is still the supraventricular tachycardia, but what happened here? We have a pause here. Here, after they give the patient adenosine, then with the adenosine, you have like as if there is a block momentarily for a while and then a return of the sinus rhythm. Okay, so if the patient is having stable supraventricular tachycardia, no hemodynamic compromise, no rush. So you can start with the vagal maneuver as we mentioned, and then you can consider giving the medications. And then if they have poor perfusion, you go for synchronized cardioversion. Okay. And here the rhythm in the middle is the ventricular tachycardia. As we mentioned, it will be wide quartz complexes. We will not be able to see a P wave. And here in this rhythm, it is a monomorphic ventricular tachycardia coming from same focus so that the shape is the same. Ventricular tachycardia, once you are seeing any patient with a ventricular tachycardia, you have to decide with pulse or without pulse. If your patient having a ventricular tachycardia with pulse, you can give your patient adenosine. You can go for synchronized cardioversion, same like what you are doing for supraventricular tachycardia. But once they are having a hemodynamic compromise, let's say a ventricular tachycardia without pulse, then you go for high quality CPR and you defibrillate the patient. We will go through the details of the management of the ventricular tachycardia. Okay, so this is the PALS algorithm for management of the pediatric cardiac arrest. So if you are having a patient with cardiac arrest, that's say you started to assess your patient and the patient is not breathing and there is no pulse, so your patient is having cardiopulmonary arrest, so you have to start high quality CPR. And while we are doing the CPR, we attach the patient to the monitor because we want to see what rhythm the patient is having. So after completing 2 minutes of CPR, what you are going to see to check the rhythm. So once the patient is attached to the monitor, you check the rhythm. In case when you are assessing your patient, there is a ventricular fibrillation or a ventricular tachycardia, but the patient does not have a pulse. Once you are seeing a VFib, this is a non-perfusion rhythm. You don't expect there will be a pulse while the patient is having ventricular fibrillation. And ventricular fibrillation, the QRS complexes are wide and they are chaotic because they are coming from multiple foci and they are chaotic and it is not a perfusion rhythm. So what you will do once you are seeing this rhythm, then you have to give your patient shock and then you continue CPR. Continue CPR after finishing 2 minutes, then again you have to evaluate your patient. Still, the rhythm is persistent, it is still shockable rhythm, then you have to give a shock. After the second shock, then you can consider giving your patient epinephrine, and during CPR, we are giving epinephrine how frequent? Every 3 to 5 minutes. And consider to put an advanced airway if the team is capable of doing that. And then if it is still there, you have to give shock and continue CPR, and then you can start medication. You can give amiodarone or lidocaine. And then don't forget to look for reversible causes, and then you have to treat reversible causes. On the other hand, if the patient is having asystole, what we mean that the patient is having a flat line, or there is a regular rhythm there, but there is no pulse. If there is a regular rhythm there in the monitor, but when I check my patient, there is no pulse, we call this pulseless electrical activity. So these two rhythms, the asystole and the PEA, they are not a shockable rhythm. So what you are going to do, you give the epinephrine as soon as possible, and then start your high quality CPR, and this CPR will continue for 2 minutes, and then you have to, after finishing these 2 minutes, you have to check the rhythm again. And if it become a shockable rhythm, then you go to the other algorithm. But if it is not a shockable rhythm, you continue CPR and continue to give your epinephrine every 3 to 5 minutes, and then you have to go for treatable causes. You have to reverse them. And the reversible causes is the H's and T's, as we mentioned, the hypovolemia, hypoxia, the acidosis, hydrogen ion, hypoglycemia, hyperkalemia, hypothermia, tension pneumothorax, tamponades, toxins, and thrombosis, pulmonary embolism, or coronary. Okay, this is how you go if your patient is having cardiopulmonary arrest. So high quality CPR, and while you are doing the CPR, allow for test recoil and minimize interruption. And once it is a shockable rhythm, you give the shock earlier, because all the guidelines are telling that the earlier you give the shock, the better is the outcome. Okay, there is a special scenario in the pediatric population is the bradycardia. Once you are seeing a patient with a bradycardia, and we all know that in the pediatric population, if the heart rate is less than 60, this is bradycardia. So once there is a bradycardia, you have to know whether your patient is having symptomatic or asymptomatic bradycardia. What we mean by symptomatic or asymptomatic bradycardia? Symptomatic, if the patient is having bradycardia with signs of poor perfusion, then this is symptomatic bradycardia. Asymptomatic, the patient is bradycardic, but the vitals, the other vitals are normal. His heart rate is normal, blood pressure is normal. Then asymptomatic, you don't jump on the patient and do CPR, but the symptomatic, you have to oxygenate them and check the vitals as you are oxygenating the patient. If the patient heart rate is starting to improve well and good, then you support the ABCs as needed. But if the patient perfusion is still compromised, despite you are giving adequate oxygenation with the bradycardia, you have to start high quality CPR. And still, the H's and T's can lead to bradycardia, hypothermia, hypoxia, acidosis, heart block, hyperkalemia, hypokalemia. Those who are having high ICP, they will have bradycardia. And those who are having toxins, also like digoxin, beta blockers, calcium channel blockers, lithium, all this can lead to bradycardia. Those who are having hypoglycemia, hypothyroidism, malnutrition, anorexia nervosa, also can manifest with the bradycardia. And as we mentioned, if it interferes with the perfusion, you supplement with oxygen. And if it does not improve, then you have to start high quality CPR. And this is the algorithm according to the PALS guidelines, how you will deal with a patient with a bradycardia. You identify that your patient is having a bradycardia. You look for the cause, but do not delay the treatment. Establish the airway. Assist breathing if necessary, especially if the patient is desatin, and then monitor the heart rate and rhythm. And the pediatric population, they are very sensitive to the hypoxia. With the hypoxia, because hypoxia to the myocardium will lead to bradycardia. So once you start to supplement oxygen, if this is the cause of the bradycardia, you will see that the heart rate start to improve. And you have to establish the IV or IO access. And if they are having hypotension or shock, you have to manage the shock as we mentioned earlier. And then you can give them epinephrine, 0.01 milligram, Q3 to 5 minutes. And you can consider also atropine for the bradycardia, especially. Okay. So after cardiopulmonary resuscitation, if the patient had return of spontaneous circulation, so this is ROSC. So if you check the pulse, and the pulse is there matching with the monitor, and of course we are not checking the peripheral pulses after CPR, we are checking the central pulses. So you feel the carotid or the femoral artery in children and the brachial in the infant up to 1 year. And if you have a qualitative waveform for the capnography, in case there is advanced airway, then it will tell you that there is return of spontaneous circulation. So if the patient is having ROSC, I have to still continue to monitor my patient, because someone who is having cardiac arrest and he had a ROSC, he is at risk to develop another cardiac arrest. So what you do once your patient had return of a spontaneous circulation, you have to support the ABCs as needed, as I mentioned. Respiratory, maintain oxygenation. If the patient is able to breathe spontaneously, well and good. If not, then you have to put advanced airway there, and you have to monitor the oxygenation of your patient. You have to maintain the saturation between 94 to 99. And if the patient is not breathing enough, then you have to intubate the patient and connect to mechanical ventilation and continue to monitor him with the end-tidal CO2 and the pulse oximeter, take the blood gas, X-ray. And as we mentioned earlier, you have to control any pain or anxiety. And if the patient is ventilated, then you have to give enough analgesia and sedation, namely Fenta or morphine for the analgesia or benzo for the sedation. For the cardiovascular, you have to check the perfusion of your patient, peripheral central pulses, capillary fill time, the urine output of your patient, the skin temperature and the color. And then you have to maintain the volume. And then you have to consider giving inotrope if still the hemodynamics are not maintained. And of course, you have to send the labs for the patient, check urea electrolytes, and then you can do 12-lead ECG, take the blood glucose, CPC, to look for the underlying causes. And arrhythmia, as we mentioned earlier, how to manage common arrhythmias. Okay, so if the patient, also you have to continue monitoring the level of consciousness of your patient. And then if the patient is having any trauma to the CNS, you have to go for the neuroprotective measures and do not rewarm your patient because hyperthermia is dangerous for the patient. And if the child remains comatose, there is a guideline for temperature management to keep the normal temperature or at least around 32 to 34 for 5 days. Okay. And if the patient is having convulsions, then you don't forget all of these measures after return of spontaneous circulation. Of course, if I'm doing CPR, I will focus on the acute management of the patient during the CPR to return him to the spontaneous circulation. Once I return spontaneous circulation, then I have to go system by system and support each system as needed. And if the patient is having convulsions, we have to treat the convulsions. Okay, and then we have to monitor the urine output cautiously for all patients. And the GI, we have to put NG tube, deflate the stomach if there is gas. Fills. Commonly, this will happen after CPR if we are not having advanced airway and we are doing bag mass ventilation. The stomach will be dilated and it will compromise further the breathing. So it's better that you put a nasogastric tube and deflate the stomach and watch if there is internal bleeding that you are not seeing. Once you put the NG tube, it will tell you the color of the gastric aspirate. And you do your full testing, labs, make sure what is the underlying cause that led to the cardiopulmonary compromise for your patient. And don't forget also to check the coagulation profile, CBC for your patient. And if the patient will having ongoing bleeding, to try to figure out what is the cause of bleed. Okay. This is just to give you like a break from all this condensed talk. The way to get started is to quit talking and begin doing. This is by Walt Disney. Okay. So now we are going to share with you the significant new and updated recommendation according to the AHA 2025 guidelines. The significant change that they mentioned early epinephrine. The goal of epinephrine administration during CPR is to optimize the coronary perfusion and maintain cerebral perfusion pressure. So early epinephrine. Because in the previous guideline, they said within 5 minutes of CPR, it is reasonable to start epinephrine. But now they said the early. Earlier is the better. Diastolic pressure to guide the CPR. It is reasonable to target a diastolic blood pressure of more than 25 milliliters mercury in infant and more than 30 in children more than 1 year. And post-ROSC blood pressure monitoring and targets. Post-cardiac arrest in infant and children is recommended to maintain systolic and mean arterial blood pressure above the 10th centile for age. And there is a new data to support the use of IV sotalol as antiarrhythmic to treat infant and children with supraventricular tachycardia and cardiopulmonary compromise that is unresponsive to vagal maneuver, adenosine, and synchronized cardioversion. The standard ways of management that we mentioned earlier, if your patient still does not respond to them and he's having supraventricular tachycardia, you can use sotalol. And neuroprognostication, early and reliable neurological prognostication after resuscitation, post-cardiac arrest is essential to guide treatment, but we should not do it very early because it might mislead you. And once you are doing the neurological exams, such as EEG, CT brace, MRI, and your neurological exam for the patient, the clinical examination, from all this data, you can come out with the prognosis. But this is challenging in the pediatric population because post-cardiac arrest, they might not show immediately decaying. So you have to wait for a time, and then this kind of patients are followed for up to 1 year post-cardiac arrest to make sure how you will counsel the families, tell them about the possible outcome, whether it is a favorable outcome or unfavorable outcome. Okay. And this is like a detailed comparison about the PALS guidelines 2022 compared to 2025. I will just go through them fast. As we mentioned, for pediatric patients, initial non-shockable rhythm, it is reasonable to administer epinephrine as early as possible, as we mentioned earlier in the previous slides. And then measuring the CPR physiology and quality. If you had advanced airway in place, then you can measure end-tidal CO2 because this will help you to look at the quality of the CPR. And as we mentioned earlier also, the post-cardiac arrest, the blood pressure management, you target above 10 centile for age. And for the prognosis after cardiac arrest, you should not depend on one item. Multiple items can guide you. Okay, and then for the ventilation and advanced airway strategy during CPR, when you are performing CPR in infant children with advanced airway in place, it may be reasonable to target a ventilation rate of 20 to 30 breaths per minute, one breath every 2 to 3 minutes, accounting for the age and the clinical characteristic, because hyperventilation is not good. And for the CPR technique, for now 2025 guideline, they abandoned the two-finger technique, which is also not very practical to do with 2 fingers only. So for all pediatric population, you don't do the 2 fingers technique. You can do with encircling both hands around the chest for the infant or with the heel of one hand. And for the foreign body obstruction, for children with severe foreign body airway obstruction, you do repeated cycles of 5 back blows and alternating with 5 abdominal thrusts until the object is expelled or the child becomes unresponsive. And the risk score should activate the emergency response system. And the targeted temperature management for post-cardiac arrest for 2025 guidelines. Here they just define the timing, and it is the same temperature target. Here they are telling 32 to 34, followed by 36 to 37.5. But here in 2025 guidelines, they said 5-day course of temperature management, either 32 to 34, followed by 36 to 37.5. And in all the cases, try to avoid high temperature as it make the body suffer more with oxygen demands. The chain of survival, previously, it had 6 links. Recovery and survivorship link were added at the end of each chain. And inside hospital or outside hospital cardiac arrest chain of survival were combined into one chain of survival of 6 links. And I put for you here the chain of survival in hospital cardiac arrest or outside hospital cardiac arrest. Here, outside the hospital, of course, you focus on the prevention, activation of the emergency response system, high quality CPR, advanced resuscitation, and because you have to dispose the patient to the health facilities, and post ROS care and recovery. And this here inside the hospital early recognition, and then the rest is just the same. Okay, and then entitled this one, measuring CPR physiology and quality for infant and children with continuous invasive blood pressure monitoring. During CPR, it may be reasonable to target the diastolic blood pressure above 25 millimeters mercury in the infant and more than 30 in those who are more than 1 year. Okay, and the prognostication, we talk about it. Okay, and for the EEG, you have to do it at least 72 hours after the cardiac arrest. And the brain imaging will be variable according to the cause of the cardiac arrest. And in adult and pediatric population, you are thinking that they are having life-threatening opioid overdose, then we have to provide antagonists such as naloxone. Okay, and this will not intervene with the quality of the CPR. Okay, post-cardiac arrest targeted temperature management for infants and children who remain comatose following cardiac arrest. It is recommended to avoid central temperature more than 37.5. So it means that we are targeting normal temperature. Okay, this concludes our talk for today. And I hope it was useful. And this is the link if you would like to register for the PALS course. This is KSU Simulation Center website. Okay.
Okay, thank you, Dr. Selma. It was a very informative talk about the big topic, pediatric advanced life support 2025, and the comparison between the differences in 2022. Thank you very much for this informative lecture and presentation. We will go through the question and answers. Just let's start with some people have written in the chat, and then also some people written here. So we'll start with the question and answers. The first one from Dr. Ala. In hypovolemic shock treated with 3 boluses, is boluses are subtracted from fluid will be replaced or not?
Okay, thank you, Dr. Ala, for very important question. It will not be subtracted because already your patient is having reduced preload, those who are having hypovolemia. So you have to fill the tank and you will not subtract this one. You will give the boluses, and then if your patient is having ongoing losses, you calculate the losses, and when you are starting the maintenance fluid for your patient, you add the losses, but the boluses are not subtracted. The bolus is subtracted only in one case, those who are having DKA, moderate or severe DKA, because we know that we don't want to expand the volume to avoid the cerebral edema in DKA, so you subtract the boluses for those who are having DKA only. But for the hypovolemic shock, no, you don't subtract.
Okay. So we go to the next question. Dr. Samah El Hussein, she is asking, is the bolus 10 or 20 ml per kg?
It is a range between 10 to 20 ml per kg.
Okay. So no, it's if he is an infant or he is a child above 1 year, it doesn't make a difference.
Yes,
It's a
according to your evaluation, if you feel that your patient need the volume, but it is reasonable nowadays because the studies show that, especially in our setup in Sudan, I'm talking, in limited resources, uh, more fluid is harmful because we have malnutrition and other things that we have to think about them. So it is reasonable that you start with 10 ml per kg and then top up. If he's still not good with 10 ml, you give another 10 ml per kg.
Okay. So we go to Dr. Kauthar. She's asking how can differentiate obstructive from cardiogenic shock if the cause is cardiac. If the cause is so she's asking how can you differentiate obstructive from cardiogenic shock if the cause is cardiac.
Okay, so the cause is cardiac, and then you are doubtful whether this is obstructive or pure cardiogenic. As we mentioned, both of them they need fluid resuscitation. Tamam, and you examine your patient before he went into shock. So if you hear any murmur, if your patient having a murmur, so this highlight that maybe he's having a congenital heart disease, and then more likely he is going through a cardiogenic shock. But if it is a cardiogenic and obstructive at the same time, because I have seen one patient, I had one patient like that. The patient was having a heart problem, and then he developed a tamponade. So still you have to use your bedside echo or ultrasound, because for obstructive, what are the type of obstructive shock? Could be tension pneumothorax, as we mentioned, could be tamponade, could be embolism or pulmonary embolism or coronary embolism. So let us talk about the common during in the pediatric. The tension pneumothorax very easy to diagnose it because needle in decompression bedside, and if you see bubbles in the water, so this is a pneumothorax. Last, so this is very clear. And if you are suspecting that the patient is tamponading, so bedside echo will show you that the patient is having a pericardial effusion. Last, so that the cardiologist will come and do the pericardiocentesis. But if you are asking about those who are having a cardiogenic shock secondary to myocarditis or other things which are new, sometimes it is difficult, but the whole market that you monitor your patient, those who were not diagnosed, and then you start to give them fluid boluses, they start to deteriorate, they could have a cardiogenic shock.
Okay. Okay, we are having some greetings from Dr. Abdullah Wasila. Actually, he's saying he's in Morocco. He's watching the African Cup Confederation. We welcome you, Abdullah, and thank you for the greetings. And we will give you we will promote you, ya Abdullah, as a panelist if you can join. فدكتورة سلمى, this is also Dr. Abdullah is saying hi.
أهلين ترى عبد الله is an old friend يعني he's a dear friend really.
Okay. طيب, we will move to the next. The next is in case of foreign body aspiration. This is actually this is without names from some of the attendees. He's asking about foreign body aspiration age more than 1 year. Will we give 5 back blows and then abdominal thrust or just abdominal thrust?
If their age is more than 1 year, we
Yes.
can do just abdominal thrust for them. We can do just because to carry them and give the back slaps will be very difficult if they are more than 1 year, and it is reasonable to do the abdominal thrust only.
Okay. So we'll go to next. If we have supraventricular tachycardia, if the patient is stable and did vagal simulation, and then no response, and adenosine not available, can I use amidron or DC shock?
Amiodarone is usually better for those who are having a ventricular tachycardia rather than supraventricular tachycardia. And we advise that if the patient is having supraventricular tachycardia and he is hemodynamically stable, to do 12 lead ECG, consult the cardiologist. They can give you alternative management for them. And if adenosine is not there, synchronized cardioversion, you can give it to your patient, but you have to give the patient analgesia because giving a synchronized cardioversion is painful for the patient.
Okay. So this one
But this
also,
is after expert consultation. You consult with the cardiologist, do 12 lead ECG, and sometimes if you treat the underlying cause, then the supraventricular tachycardia will end. Yeah, make sure that you check your electrolytes for the patient, potassium, calcium, hydrogen ions, your blood gas is done, and you eliminated the cause, because I have seen multiple patients after simply they are given Ventolin for asthma, then they develop supraventricular tachycardia. Then once you lower the dose or space the Ventolin further, the supraventricular tachycardia disappeared. So not only you think about the antiarrhythmic medication alone.
okay. So we'll have, in case of foreign body, this is already answered. After 1 year of age, do we do back blows? This is also another question, but already we answered it earlier. Uh, um, this one. In malnourished patient with a shock, the role is 15 ml. I think he's saying the guideline. The guideline saying 15 ml per kg ringer lactate in 1 hour. But sometimes presented shock near arrest. Can I give normal bolus, but is small as in cardiac case, 5 ml to 10 ml per kg saline or half saline, then continue as usual? I think he would like to ask the question in a special population like malnourished children who presented with a shock. Can he give usually they give 15 ml per kg ringer lactate over 1 hour, but sometimes he's saying that the shock is so severe and the patient is also arrest, yeah, near arrest. So he's asking, can he give 5 to 10 ml per kg saline or half saline, then continue as usual or not? I think this is what he's trying to go to.
Okay, his question is having two parts.
Mm,
For resuscitation fluid boluses, it is recommended that I'm not talking about the PALS guidelines now. I'm talking about the guidelines in the pediatric population in general. So you go with isotonic solution. Isotonic.
yes, yes,
Isotonic and balanced solution. So ringer lactate is a balanced solution. Still, you can use it for resuscitation. Isotonic saline, you can use it, but not half saline.
yes, I agree.
Normal saline. Last,
Yeah,
this is the part, this one part of his question. And as I mentioned, the earlier studies say that large amounts of fluids are harmful in the malnourished population. So if your patient is having a shock and he's malnourished, you start with 10 ml per kg. 10 ml per kg. Rather than 15 ml, start with 10 ml per kg. But this 10 ml per kg, you reevaluate your patient and then you can repeat your bolus.
okay. And the duration also is important because they are fragile and they might not
Yes, they are
tolerate.
prone to develop heart failure and they
Yeah.
decompensate. Yes.
Okay. Okay. So we come here to the last question in the question and answers before we go to the chat. When you need to use epinephrine or albuterol nebulized in bronchiolitis, when do you use epinephrine or albuterol nebulization in bronchiolitis? This is from Dr. Marwa Mubarak.
Like, up to date, all the guidelines does not support giving the albuterol or epinephrine. The guidelines support that you give them 3% sodium chloride for the bronchiolitis. تمام. But we are still in practice. We are giving them either salbutamol or epinephrine and see the response. Your guide will be with the response. So if your patient responded well with the racemic epinephrine, you continue to give it and check the response. If he continued to respond with the bronchodilator salbutamol, you continue with the salbutamol. If he responded with the 3% sodium chloride nebulization, you go with that one.
Okay.
Because all of this is just symptomatic treatment. Because we know after the disease, the bronchiolitis will reach the peak, and then after that, the patient will start to improve.
Okay. Okay, Dr. Salma. This one also from Dr. Ibtihal. She is asking about drowning, or I think submersion. So she said, really, we don't deal with this such cases. So any comment from you, from your side on this one about drowning?
Drowning, one of the tough cases that will present to the intensive care because they are having the trauma, they are having the aspiration pneumonia, and they are having the cerebral edema. So you have to support them, you have to maintain the temperature, and the prognosis will be dependent on the submersion time, whether the CPR was done at the scene or not, and their initial blood gas. And then you monitor them, and then I have seen that really the initial blood gas and the submersion time and the CPR, these three really will guide the prognosis of the patient. If the submersion time is prolonged, then the prognosis will be less because the injury is more, the hypoxia is more, the multi-organ affection is more. And yeah, I have seen variable. I have seen patients with near drowning, and they recovered, and some of them with disabilities, and some of them become CP, and some of them died. It is one of the tough scenarios that we are seeing.
Okay. So we have also this one. Thank you for the nice presentation. What about asthmatic patient with supraventricular tachycardia?
Yes, I have seen this kind of patients. So, asthmatic patient with supraventricular tachycardia, we try to lower the dose of insulin because it's still asthma. It needs a bronchodilator. We try to lower the dose and then try to manage them with the other modalities. We go more with the magnesium sulfate. We make it regular, Q4 hourly, Q6 hourly, IV magnesium sulfate to bronchodilate them, and then uh, relax the myocardium from because with the supraventricular tachycardia, then the filling of the heart will be compromised, and the patient might be also will go to the shock with the supraventricular tachycardia. That's why you have to relax the heart, but at the same time you have to manage the asthma. So you go with the other management of the asthma, you go with the steroid, but steroid will take time to work, and you go with the magnesium sulfate, and the Ventolin, you lower the dose to the minimum effective dose.
Okay. Okay. So I think this will be for the question and answers. Okay. Regarding the chat, so in the chat, we'll go from down from the last question to the first question. When not to give adenosine in SVT patient. They mentioned it may lead to arrest, especially at ER level in context of not knowing if the patient might have other arrhythmia. This is Dr. Alawiya. She's asking these questions. When should we do not give adenosine in a patient with supraventricular tachycardia?
The advice, if the patient is having supraventricular tachycardia and he is hemodynamically stable, you go with the vagal maneuver because this is the safest that you can do for the patient. Adenosine, what the guidelines suggest that if you consult the expert will come do the 12-lead ECG and then under their umbrella to give the adenosine. Last, but and I believe for those physicians in the ER, it is safe for them. They can give the adenosine 0.1 milligram per kg, and then consult the expert. It can lead to blocking for a short duration this adenosine, and then it is sometimes harmful, not all the time. But this will should not forbid us from going through the guidelines and give the adenosine. And very rarely that you have adverse events with the adenosine. So it is reasonable that if your patient is having supraventricular tachycardia and you tried the vagal maneuvers and you consulted the expert and they advise you to give and you are in the critical care areas, so it cannot be ICU or ER, you can still give the adenosine. In the appropriate dose, you go with zero point 0.1 milligram per kg and the second dose will be zero point 0.2 and don't exceed the adult dose. As long as you are going with the guidelines, it is safe.
Okay. So we go for Dr. Samahir. She's asking sotalol approved in supraventricular tachycardia. If first line not affected. I think she's asking is sotalol in the to be used as a first line in supraventricular tachycardia.
Not a first line, because basically sotalol is a non-selective beta blocker, and it had the potassium channel blocker, so that's why it's class 3 antiarrhythmic medication approved initially for the use in the adult. And this in the new guidelines, they mention if all the things that you are trying for the supraventricular tachycardia failed, you can use the sotalol. So it is not a first line drug at any point, and it had a prolonged action. That's why you should not use it as a first line.
Okay. Okay. So this one, thank you, Dr. Selma. Also, they are thanking you for this. طيب. Dr. Halima is asking when to call a shock a refractory shock.
Excellent question. Because sometimes you will give the fluid. If your patient responded to the fluid, this is a fluid responsive shock. Then after 3 boluses and still your patient needed hemodynamic support, you started inotropes, 1 inotrope. So this is a fluid refractory shock. And if after starting the first inotrope, second inotrope, and still your patient is into shock, so this is catecholamine resistant shock. So once you are starting 2 inotropes and you are facing catecholamine resistant shock, you go and think about adrenal insufficiency, you consider giving steroid to the patient.
Okay. Okay. So we got this. Okay. Okay, I think this Al Masri, she's asking about post cardiac arrest neurologic prognosis. She's asking about, I think, what is the neurologic prognosis post cardiac arrest?
The prognosis, because some patient after cardiac arrest, they might suffer cognitive problems, or they might have disabilities, or they can have learning difficulties. So you have to continue to assess them up to 1 year. But your assessment will not be done immediately after the cardiopulmonary resuscitation. At least you wait for 3 days to do the EEG and continue to do neurological exam and collect the data about the patient, do the brain imaging also for the patient. But it should be done into intervals so that to define how is the prognosis for the patient. And this, as we mentioned, it is complicated because according to what is the cause of the cardiac arrest for the patient.
Okay, thank you. Okay, so we have the last 3 questions. This one is if there is any role of vasopressors in hypovolemic shock?
And to hypovolemic shock, the goal of the management to try to restore the volume. So you give fluids, 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 fluids. So if it is purely hypovolemic shock, you go with the fluids. And usually it is fluid responsive.
Okay. This one is again the issue of the DKA. He's saying in DKA with shock, usually we do not subtract according to the guidelines. We do not subtract the bolus. Already we talk about this one. The last one is a question about the warm and cold. Septic shock, is it warm or cold?
Okay, also another good question. Septic shock is a kind of a distributive shock. It can present warm or cold. If the patient is having a warm shock, you start the fluid policies as usual, and then you go with the norepinephrine. This is the difference in the management. And if they are having a cold shock, fluid policies, epinephrine. So the difference, if you are having a warm shock, you go with the norepi once you are reaching for the inotropic support. Of course, norepi is a pressor, and if they are cold, you go with the epinephrine. But septic shock can present in both ways. It can present with a cold or warm shock.
Okay, very clear. Okay, I think that's all with the questions. We thank again Dr. Selma, and if you have any advice here, Dr. Selma, about if you have any website or any links that can be shared with the group, please send it to me, and then we can send to them. Also, if you have any materials you want to distribute, برضو it will be very thankful if you can share with us any materials.
I would like also to thank you, Dr. Muhammad Karrar, since you coordinated nicely and you were communicating with me in a nice ways and you were patient. And Alhamdulillah, yani, we would like to share our experience with our colleagues. And I have one AHA journal. I will share it with you, inshallah.
Okay,
Okay.
thank you very much. And I think that will be it. Thank you for the attendees, and keep coming into our webinars and share any discussions, and see you in another webinar. Thank you very much, and have a good night.
Okay, thank you, Dr. Muhammad. Okay, goodbye.
Thank you.